Welcome! With me today to discuss diabetes is Dr. Thomas Pitts, a practicing endocrinologist at Northwestern Memorial Hospital in Chicago and clinical associate professor of medicine at Northwestern University's Feinberg School of Medicine. Dr. Pitts is a national speaker and lecturer on diabetes care in urban and rural populations, and Dr. Pitts is the co-chair of the Centers for Disease Control, the CDC, their Illinois Diabetes Coalition. Dr. Pitts' areas of research include diabetes detection and management, and he also treats lipid and thyroid issues. Am I forgetting anything?
You said more than enough.
Well, I'm going to start off. What I'd like to ask you is just to go over the disease of diabetes, a definition. What is diabetes?
Well, diabetes is many things to many different people. I try to think of it as a metabolic or energy-related disease in which we lose the ability to harvest energy or calories from different foodstuffs, principally glucose or starches, but also fats and proteins as well. As a consequence of that, people with diabetes generally have less energy to run the biologic processes of their bodies. They have less ability to heal or recover from infections or wounds. They also have less ability to maintain structures such as kidney, such as nerve function, such as heart.
And can you discuss the difference between type 1 diabetes and type 2 diabetes?
There are several forms of diabetes that we use in clinical medicine. The most common form of diabetes, the kind that about 80 to 90% of Americans tend to have, is called type 2. This diabetes is manifested by, it's a genetic disease, seems to be principally manifested by people being able to make some insulin, but not enough to cover all the metabolic demands. They generally present with no symptoms at all and are picked up in today's time by standard blood glucose tests for other reasons. Type 1 diabetes, on the other hand, are a group of generally younger people, but also can be older. They effectively make no insulin, and they're generally diagnosed at a time when they're very sick, generally and very weak and in a metabolic crisis, you might say. And they usually have to be admitted to the hospital for an emergency hydration and correction of all sorts of electrolytes. Most type 1 patients are diagnosed before the age of 21 or 22, but we do have populations of people who are diagnosed in their 7th, 8th, and 9th decades of life. They are at risk to develop something called ketoacidosis. A way to think about that is complete loss of ability to handle not only glucose, but fats as fuels, and as a consequence, the fats are burned too rapidly. The residue of the fat burning is a toxic acidic process called ketones, and in large amounts it tends to overwhelm the body and can cause death. These group of people are generally managed with insulin their entire lives, and this contrasts with type 2 diabetes, who may or may not be managed with insulin, but are also managed with a number of other medications, including both injectables and tablets. A third form of diabetes is called gestational diabetes. And this is a fascinating group of women who do not have diabetes before pregnancy. They develop diabetes sometime during the pregnancy. And when the pregnancy is over, they often revert to normal or non-diabetic states. Unfortunately, within the next 10 years, about half of those women will become full-time type 2 diabetics.
I didn't know that. Amazing. Let's talk about abnormal blood glucose levels. So what is the normal blood glucose level? What would you consider to be pre-diabetic? What is, the number for diagnosis of diabetes? And also, if you can tag on it to explain A1C.
Well, these are very important concepts for diabetes management. People who do not have diabetes generally have a fasting blood glucose or blood sugar, in other words, a blood sugar taken before the first meal or the first morsel of food for the day, of under 100 milligrams percent. In fact, most of them are under 90. People who have blood glucoses above 100 but under 126 milligrams percent are generally called pre-diabetic. And you might think of those folks as having a blood glucose higher than normal, but not high enough to be frankly diabetic. Now they become an important group for us to focus on because the chances of them evolving into a full-time diabetic are much higher than those folks who still have blood glucoses under 100. So if you're paying attention to the numbers then, 126 gets to be the cut point. Those men and those women and children, for that matter, who have fasting blood glucose values at 126 milligrams percent or higher are generally diagnosed as having type 2 diabetes, and they will have, of course, higher blood glucoses after they've eaten a meal.
Okay.
The hemoglobin A1C is an interesting test that's been in clinical use for about 2 decades, maybe even 3 by now. And what that is an attempt to look at blood glucose sugars not just in the morning, not just after a meal, but all through the day, all through the night while we're sleeping. Chemically, what this represents is the tendency for a molecule of glucose or blood sugar to be chemically bound to a protein. In this case, the protein is a protein associated with our red blood cells, so-called hemoglobin. Men and women and children who do not have diabetes generally have about 5.5% or less of their hemoglobin bound up with a glucose molecule. People who have diabetes generally have a value of 6.5% or higher.
So can you talk about the causes of type 1 diabetes and type 2 diabetes?
Type 1 diabetes is probably more than one cause. We generally think about most of type 1 diabetes being an autoimmune disease. And by that, I mean that we are making antibodies against our own apparatus to make insulin. In this case, it's a certain part of the pancreas gland, and we call those the islets. And in folks who have type 1 diabetes, there's evidence now that they have these antibodies in circulation. And in autopsy studies, you can actually see where the pancreas, in particular the islet cells, have been destroyed in large numbers, therefore reducing the ability of the pancreas to make even small amounts of insulin. Now, there are some other forms of type 1 like diabetes that are not autoimmune, but this is the major cause and the thing we mostly think about in most type 1 diabetes. Type 2 diabetes is a genetic disease as well, but it doesn't involve an autoimmune response. It tends to have a conditioned response where we're unable to make all the insulin that we need. We can make some of it, but not all of it. So that in our young lives, when we are most efficient, sometimes that amount of insulin is adequate, and we see normal blood glucose values. As we age, as we get other kinds of illnesses, as we have a reduced muscle mass or an increased fat mass, and we tend to associate that with body resistance to insulin, then the diabetes tends to show up as higher and higher blood glucoses. This disease is passed on from generation to generation. The number of genes involved can be as few as 1 to as many as perhaps 40 or 50 genes. And we can see a diversity in type 2 diabetes because some folks get certain complications a lot sooner than others. And so really there's a spectrum of complications that we see in different groups of folks with diabetes.
Mm-hmm. I have a quick question to ask about when you mentioned before when we were just insulin resistance. I'm going to throw that out. I've read where the hereditary factor is you're prone to insulin resistance, and then if you're not eating right, you're not exercising or whatever, that you can flip the switch and it becomes full-blown diabetes. Do you believe that that's true, or do you think that you just inherit diabetes, period?
Well, my personal thought about this, Candy, is that there's a whole spectrum of these individuals. There are people who never eat correctly, never exercise, are grossly overweight with body mass indexes in the 40s and 50s, no diabetes. They don't have diabetes at young ages, middle age, and not advanced ages as well. They may succumb to other illnesses, but they never do that. So in this group of individuals, they have insulin resistance, but whatever that takes on, they have the reserve to make large amounts of insulin. There are other groups of people who are lean, who exercise, who eat wonderfully, and they still get high glucose. They don't have type 1, but they do have type 2 diabetes. And so for that group of people, one could think that their ability to make insulin is substantially compromised, but there may be some other downstream effects as well that increase their risk of complications. So again, there are a whole spectrum of illnesses. Part of diabetes now is also associated with a tendency toward obesity, and there's been some research to suggest that, at least in some people with diabetes, there's a change in satiety, so people have more difficulty reaching a level of fullness, and they tend to overeat, and that may aggravate the diabetes as well. So we really have a whole spectrum of clinical conditions wrapped up under one hallmark of high glucoses, or the flag of type 2 diabetes.
In all your years of practicing endocrinology, what have you seen in diabetes?
Well, it's been
Do you feel it's an epidemic?
It's an epidemic. We used to talk about 16 million folks with diabetes. You go to the CDC website, they're talking about 29 million. We used to talk about 5 or 6% of the population. Across most states now, it's closely to 10%, 9.5% here in Illinois. We used to talk about, however, roughly a third of individuals with type 2 diabetes not recognizing that they have it. That number is now about 25%. So our ability to have programs that identify symptoms or identify who's at risk, and that may be even more important than symptoms, is expanding. So this is a conversation that's going around, that people are talking amongst their families and friends and various organizations. So I think the conversation is much broader. Another point to make is that when I started practice, there were basically insulin in just a couple forms of it and a couple of pills. And no matter what kind of diabetes you had, what other side effects you had or tolerances you had, you only had those two tools in your tool belt. Now we have each year an additional, not only additional medication or strategy, but a whole different mechanism, so that the possibility to have multiple defects addressed at once are better. And in my mind, I'm thinking that in the near future, it's going to be more and more possible to custom treat type 2 diabetes, depending on what your characteristics are, what your age is, what your needs are, how much insulin you need versus how much insulin resistance you need to do battle with, you might say. In the type 1 field, there are more and more sophisticated ways of delivering that all-important insulin. And the technology now is getting very, very close to what we call closed loop, where machines are able to detect glucose and then calculate the correct amount of insulin in real time to compensate for that. We're not there yet, but we're very, very close. And of course, this would make a huge difference in management of type 1 diabetes. And of course, in the transplant world, the number of individuals who are getting transplants, both kidney and pancreas, to restore kidney function and to, in effect, wipe out the diabetes symptoms and high glucoses, those are becoming more and more available as well. Of course, these are cadaver transplants, so the number available limits that possibility. But there's also a technology that looks at converting stem cells, and for your audience, that's that pluripotent or multiple potential cell that has the ability to develop any kind of organ at once and then produce that material unique to that organ. So in other words, to build brand new islet cells that can make new insulin. Unfortunately, the cost has gone up too. And so our need to be able to afford these technologies, afford these medications, and afford the physicians and nurses and assistants are going up, and we need the ability to afford that.
Mm-hmm. And what about when we were talking about an epidemic and you mentioned the numbers, what about type 2 diabetes in children? I mean, type 2 diabetes was always thought of as adult onset diabetes, and to now hear about children being diagnosed with that. So, what are your thoughts about that?
Well, the type 2 diabetes, not universally, but largely seems to correlate with teenage obesity. So, as we have a generation of kids who tend to eat a higher density of calories, in other words, more fat, if we have a population of kids who spend more time at computers or in sedentary positions, as we have a population of kids who are prone not to be outside exercising and playing, both inner city kids as well as across the nation, there seems to be a coexistent epidemic of obesity. With this obesity and the diabetes of their parents and grandparents, what used to be the age of show up of where diabetes would show up used to be about age 41, and now we're having kids show up in their teens or right around adolescence, and then on up from there.
And what is their future going to be like? I mean, when you
Well,
mention, you mentioned all the offshoot diseases of diabetes, renal, cardiac, whatever. And
yeah.
so if you're getting diabetes earlier in your teens, then does that mean that you are going to be developing cardiac issues, renal issues, vascular issues earlier than, let's say, your parents or grandparents would have?
That would be my guess as well. It would mean that these kids would need a lot more health care than the average kid would get. The risks were much greater. And then for those children themselves, as they developed into full adults, their careers of earning power are going to be reduced as well. So their top wage, just at a time when they might be entering the top income earning of their life, that might be the time when the diabetes complications overtake them and take away a significant part of their future. So it's a cost for them. It's a cost for the society that has to support them. And it's at a time when kids are not really mature enough to really deal with concepts of chronic disease.
Well, you mentioned the economics of it. So what is the cost for, care of a diabetic in this country?
We used to calculate that the care of a diabetic was roughly fourfold higher than a person without diabetes. That was before some of the technologies we have now. So it's possible that could be a factor of 6 or 8 now.
Yeah. Well, I'm shocked by the number of satellite dialysis units that I see in various cities and suburbs. I'm just can't believe it.
So we're blessed to have lots of dialysis centers. We're cursed because we need them.
That's exactly it. You're right. It's true. So I want to also ask you about blood sugar. When we talk about high levels of blood sugar, what about high levels of insulin and its inflammatory effect on the body?
Well, insulin is an anabolic hormone. So by that I mean it's a storage hormone. It causes a net storage of glucose, a net storage of fat, and a net storage of protein. So in circumstances where either we're giving extra insulin because a person's insulin resistant, or because they're naturally making more insulin because their bodies are insulin resistant, you might assume that they would tend to become fatter as they protect their fat masses to a greater efficiency than average, and they would succumb. They would have, in addition to the diabetes, all the comorbidities we associate with obesity. And of course, one of those obesity complications that turns out to be in greater observation are cancers. So breast cancers, colon cancers, pancreatic and gallbladder cancers. There are a large number of cancers now that We don't have the exact cause and effect, but we clearly have an association.